And I'm looking forward to hear Dr. Yalcin's insights about hypertrophy and stressed heart morphology and how this can, what can we learn about this? And hopefully Dr. Yalcin learn more and reduce the incidence of heart failure with this. This is what we'd all like to learn from you. So please let me introduce you a little bit more because I have some things that I would like to say about you. You are currently in the Department of Cardiology of Mustafa Kemal University in Antalya, Turkey. Dr. Yalcin is also a Fulbright visiting professor at Johns Hopkins University since 2009. He's recently been a visiting professor at the University of California in San Francisco Health. He completed his medical degree at the University of Akdeniz in the Mediterranean. In 1989, he's a resident of the Minister of Health of Ankara Emergency Hospital in Ankara, Turkey from 1990 to 95. He was a fellow at Leeds University Hospitals in the United Kingdom and also the Cleveland Clinic Foundation here in the United States. And he's also worked at Baskent University in Adana, Turkey. He has many publications in peer-reviewed international journals, and it is such an honor to have you as a keynote speaker, Dr. Yalcin. Please educate us on the stressed heart for morphology. We'd like to learn more. Thank you.
Thank you very much, Dr. Yang. As you mentioned, we've been focusing on this segmental morphological details after discovery of real-time three-dimensional echocardiography. As you mentioned, again, we started our first studies in Cleveland Clinic using real-time 3D 2 decade ago. I hope you can see these slides, right?
Yes.
Okay. As you know, the normal geometry look like an oval shape. On real-time echocardiography, we are able to see segmental morphology and details. We can recognize some regional details between the diseases with hypertrophic geometry. As you can see, some of the patients with heterogeneous morphology is completely inconsistent with classical knowledge that we learn in medical schools. For example, Laplace law, if every point of the myocardial or endocardial border face equal wall stress, the severity of the segmental hypertrophy should be equal over each segments. But as we can see on the screen, we can face very heterogeneous morphology like this. This is a hypertensive patient. In the time, we have seen similar morphology, we can say that ampulla shape in acute stress cardiomyopathy. And a long time ago, we published the similarity between acute or chronic, doesn't matter. There is a very, very similar geometric appearance in this group of patients. And then recently in UCSF, University of California, San Francisco, last year, we focused on the aortic stenosis. So we have seen that no matter emotional, cognitive, mechanic, or functional, due to increased afterload in hypertension. In other words, independent from stress type, this morphology looks important in this group of patients. And long time ago, we again focused on the function, and we quantitated using tissue Doppler under stress, and we found under stress this region, septal base, gives hyperdynamic response to stress. And we believe now, I will talk about the validation studies on small animals using third generation microscopic ultrasonography, but we believe this morphology is very complex and affected by different type of stress, a variety of stress stimuli. And at Johns Hopkins, with Fulbright support of the US government, we have seen it's really is the first geometric distortion during the remodeling, no matter you use physiologic or pathologic stress. Physiologic, animal treadmill for mice. Pathologic one is transaortic construction. And we published the details of all these segmental details. As you can see, quite similar real-time 3D and animal remodeling progression by the microimaging. And we also discussed the MRI and CT findings. We use, of course, ultrasonography, and we still believe ultrasonography is enough, and you can use quantitative additional methods as well as hemodynamic parameters with the cardiac images. This is MRI, similar early distortion of basal septum. All these MRI findings have been published after our publications. And we suggested and criticized those MRI patients. Exercise hypertension should be recalled, and blood pressure monitoring is a must for even young patients, young individuals. This quite regular human heart with more dominant basal segment compared to other segments, but we don't always see this kind of regular morphology. We can see very heterogeneous morphology like this or this one, very dynamic. We are concentrating on the stress scores in these patients. We presented our first results during last month in Athens during the European Society of Hypertension annual meeting. As you can see, regional geometry is quite heterogeneous. And 2 months ago, we published in European Heart Journal. Actually, that was a response to a multicentric study. They, in aortic stenosis patients, they suggested that concentric hypertrophy is very effective on mortality, but the measurement points only one myocardial cross-sectional measurement. We believe it's not enough, and we, as I mentioned, Along 2 decades, we are trying to underline the importance of basal and apical discordance documentation for each patient. And I believe around the world, we need a collective data on that. Maybe it's important for mortality as well. I also personally believe that the discordance between basal and apical wall thickness and function discordance is important on the disease progression. And as I mentioned, we published our hypothesis, like it's time to assess left ventricular segmental remodeling. Really, as you can see, quite again, heterogeneous morphology. It's hard to take a cross-sectional measurement to assess the global left ventricular function or morphology. You have to focus on all segments, apical, middle, and basal. And we criticize again this multicentric study, and we mentioned that this is not enough, and we again suggested to have collective segmental data around the world. And we also mentioned, because of the multiple geometric differences in human being, it's hard to detect the prevalence, real prevalence of this particular finding. Those findings, specific stress-related focal findings, are completely consistent with complex symptomatic picture of the particular group of patients. And we call this region as extremely sensitive region. And after some papers in Journal of Hypertension suggesting that certain quantification for septal base, we criticize that it's impossible because individually heterogeneous morphology cannot be measured using specific method. And I'd like to conclude my speech with saying stress heart morphology seems quite complex phenomena, possibly affected emotional mental overdrive beyond pure hemodynamic stress due to hypertension. Complex imaging findings also are consistent with adaptive phase, which include both septal basal hypertrophy and hyperdynamic segmental motion under stress, showing irregular nature of human stress heart morphology, which is likely to depend on cognitive function compared to regular remodeling in animals, according to our previous animal validation studies. We focus on a new issue, specifically on heart failure, as heart failure frontiers, with Mario Garcia. He is the head of Albert Einstein. And we invite all of participants to send papers, heart failure papers, to this issue. The impact factor now is 5 because very interesting publications came up recently. Thank you very much.
Well, thank you so much, Dr. Yalcin, for that enlightening talk. on basal septal hypertrophy and stressed heart morphology. One thing I wanted to ask you about is, should we be getting imaging? Because you mentioned about even young people being affected with this. How can this be corrected if you see let's say a curvature in the septum early on? Can this be corrected is number one question. And if spotted early enough, and if so, would this reduce the incidence of the heart morphology and cardiac remodeling if it were corrected?
Dr. Ag, we have several research groups. One of research group focused, this is really complex phenomena, aging heart. The other group focused on cortisone and basal septum. When we look at the patients with basal septal hypertrophy, you can see long-term antidepressant using for the elderly group especially, high stress score. And recently we focused on the protruding part into the cavity and into the left ventricular outflow. But as I always mention, we have very limited data. If we have more collective data, I strongly believe that we can, in the future, maybe separate the stress type in the particular patients according to specific differences on the morphology. But it's very hard.
I see.
We need time, of course.
I have Dr. Shamir
yes.
would like to ask you a question, Dr. Yalcin.
Good evening. I thank you very much for this lecture. In fact, I was in Cleveland Clinic in 1984. Dr. Robert Tarazi and Fitnat Fuad Tarazi, the first to initiate the subject of basal hypertrophy from hypertension, not from congenital hypertrophic cardiomyopathy. So, but I did not follow what the conclusions or the progression of this finding. But where the basal hypertrophy was initiated in Cleveland in Research Institute with Dr. Tarazi. Thank you.
Yes, I was there in '98, and it's been really useful to have real time. That's why it accelerates more studies on this topic. But it's very important. I heard about it. But real time is three-dimensional is, as you know, much more beneficial to compare the segments. Thank you very much.
Thank you.
Thank you. Does anyone else have any questions for Dr. Yalcin? I think his presentation was very thought-provoking. And one other last question that I would like to ask you, Dr. Yalcin. You mentioned in your talk about recalling exercise and stress, with people with hypertension. Can you comment on that a little bit? Because we are taught that exercise, is helpful. I mean, everyone has to do it with respect to their own condition, but it's helpful. So I just like to hear your input on that. You showed a brief article about it, and I know I can look at this, but I thought that was interesting. Can you tell us a little bit about what your thoughts are about this?
It's very, very important point. Because of the limited time, I couldn't put all of the MRI studies. MRI studies is really limited capacity because they did not, majority of them did not follow up the hemodynamic parameters. And we focused on, there are some groups around the world in America and Europe focusing on basal septal hypertrophy, but all of them work on resting parameters. In this issue, you have to look at dynamic reaction under stress of the particular tissue. And we strongly believe that exercise hypertension is produced first basal septal hypertrophy before global LVH. I also personally believe that it will be a additional stage, formal stage, before global left ventricular hypertrophy. But of course, our data is very limited. We need more collective data to prove it. Yeah. After our initial ultrasonographic dynamic studies, we combined with tissue Doppler echocardiography, bicycle ergometer, and the others, MRI studies have increased recently, and they showed that athletes, long runners, have some tissue pathologies on MRI. Now we believe that in human being, long time neurohumeral elevations in even very healthy individuals could be very dangerous. In MRI, in athletes, they found the fibrosis, local fibrosis, and we also do not trust as much as before the 24-hour blood pressure, mean blood pressure. We now clinically focused on the fluctuations. According to our previous data, exercise hypertension is a fluctuation of the blood pressure. So practically, it's very, very difficult to personalize these observations. But I believe now in Athens during ESH meeting, there were a lot of abstracts regarding that. We believe those fluctuations are much important and dangerous than the 24 hours mean blood pressure records. But we need more data.
Yeah. Any thoughts on when you say early imaging? Should people in general get imaging of their heart just to get an idea of what things to come, just so they're informed, so that they can modify their lifestyle if needed?
In our majority of our publications, to attract the attention of the readers, we used incidentally detected basal septal hypertrophy. But even in my clinic, when I go to echocardiography lab, I have seen on the screen very typical basal septal hypertrophy from an invasive guy. So majority of the physicians, as ours, may not be giving enough importance on this topic. Of course, if you see basal septal hypertrophy, I strongly suggest exercise test, but before and after and during the test, you have to take blood pressure recording.
Okay. Well, thank you for your recommendation, and looking forward to maybe having some of this information available to us, for the general population. to take proactive measures to reduce the incidence of hypertrophy and exacerbation of heart failure. So, so thank you, Dr. Yalcin, very much. It's very informative.
Thank you very much.
You're welcome.